Well, first of all, when we are evaluating a patient for intervention, and this is coming from the ESC guidelines, basically what we want is to integrate all the clinical and imaging aspects that can help us to assess the individual patient in terms of providing the best management. We know that the big question in valvular heart disease is basically when to intervene. That's the basic clinical question that we have in our individual patient. And that's all the questions that and the interrogations that we have when we look at the individual patient, try to define the right timing, not too late, not too early, to identify the right timing for intervention. And here is where the use of imaging can really be very useful. You heard already a lot about the use of echocardiography. Other imaging modalities are becoming more and more relevant in improving the assessment of the individual patient. And that's where the use of techniques such as the use of strain imaging that I will detail in just a few minutes can again add some information that again can help us to identify the best timing for intervening on the individual patient. This is the concept that we currently follow, which is the concept basically again of patient-centered evaluation for intervention, where we very much recommend, particularly for the more difficult patients, the integration of all the information into heart team decision. In my place, in my hospital in Lisbon, we have weekly meetings of the heart team to decide precisely on the decision-making of the patients, what type of procedure, what type of intervention, the right timing, and this is discussed among the team, which includes, of course, the surgeons, the interventional cardiologists, the imaging, and so on. And I think that has actually been a big step forward on the way that we manage patients with the valvular heart disease. Well, if we look at the recommendations on the indications for intervention, either aortic stenosis, aortic regurgitation, mitral regurgitation, and I'm talking mostly about, of course, the left-sided valvular heart disease, we can see that looking at ventricular function, and particularly using ejection fraction, which is an old parameter, I would say is the best we still have, although with a lot of limitations. Ejection fraction basically is just looking at volumes, so it's the impact on volumes of the abnormalities or the changes in left ventricular function. But it's still used as you can see here, as a marker, as a threshold, particularly for the asymptomatic patient, in this case in aortic stenosis. And you can see that the threshold is put at 50% of ejection fraction for the intervention in asymptomatic patient with aortic stenosis without any other cause. And at 55%, intervention should be considered if there is also no other cause for explaining the severe aortic stenosis. So the use of ejection fraction still as one of the parameters that is included in the algorithm. And again, this is the algorithm that is used in the and it's recommended in the European guidelines. The American guidelines are very similar, with a cutoff at 50%. And if the patient has lower than 50% of ejection fraction, it should be evaluated in the heart team for consideration for intervention. And here we're talking about, of course, the management of asymptomatic patients, where the use of ejection fraction is still considered as an important parameter. In aortic regurgitation, the same, using end systolic diameters as well as the ejection fraction still as a reference for intervention in these patients. And you can see here from the algorithm to assess the patients with aortic regurgitation. If the patient is asymptomatic, the threshold of the 50% of ejection fraction and end systolic diameter of 50 millimeters is still considered as relevant to put indication for intervention in these patients. And again here, and we just heard a very nice talk on the low flow, low gradient aortic stenosis. So the inclusion of the flow status can actually help also to identify these patients. But the question is, and this is a work that we've done, it's a multi-center work that we've done in patients with bicuspid aortic valve disease. We included here more than 2,600 patients that were evaluated in the registry on bicuspid aortic valve. And what was shown here was that there was an impact of left ventricular ejection fraction on the outcomes of patients with bicuspid aortic valve disease. And actually the threshold here was put at 60% of ejection fraction. And that's why the recommendations or the conclusions from this study was that in patients with bicuspid aortic valve, the risk of adverse clinical outcomes increases significantly when left ventricular function assessed by ejection fraction is less than 60%. And these findings suggest, and that's a recommendation, that probably we should change the threshold from 50 to 60% for AS and for AS and AR, and for multiple valve disease for 55%. So here, still using ejection fraction as our reference, and again, knowing the limitations of ejection fraction. And that's why new parameters came, and one of them is the use of myocardial deformation parameters, so the use of strain and strain rate, which basically provides information on myocardial function. There are also some limitations when we use myocardial deformation parameters. For instance, load dependence exists also when we are using myocardial deformation parameters. But in this case, we can actually use what is called the speckle tracking, which basically follows the changes between motion of the speckles and in the myocardium throughout the cardiac cycle. And it can actually provide information on different segments, and then can provide sort of a bullseye, as we can see here, with the assessment and calculation of global longitudinal strain. So this is basically obtained in the apical views, where we can actually have information on each segment, and then overall information, which provides this number of global longitudinal strain. Global longitudinal strain has been the evolution in terms of the use of ultrasound in echocardiography, and now it can even be included 2D strain, 3D strain, that can be also assessed by these new machines and new technologies. And if we look at the use of speckle tracking in echocardiography, it basically gathers the optimal two-dimensional digital echocardiograms, although it's not as much dependent of image quality as, for instance, the calculation of ejection fraction. It uses image processing algorithms that identify this small, stable, what we can call myocardial footprints, which are the speckles, which are the ultrasound speckles that are measured and assessed by these algorithms. And those are tracked over the cardiac cycle. So the displacement of these speckles can actually provide information about myocardial deformation. So it's not just looking at the volumes, but actually looking at the myocardium itself and looking at myocardial deformation. We can see some of the clinical applications. Of course, some of the sources of variability, as I mentioned, there are some limitations also on this technique, but I would say it's an added value in terms of improving the way we can actually assess myocardial function. And that has been translated into different studies. This is, for instance, the use of myocardial strain in aortic stenosis, in aortic regurgitation, just a few samples, in mitral regurgitation. So providing already quite some information in terms of data that can help us to include this in our observation. Here you can see the use of left ventricular global longitudinal strain in a patient with severe aortic stenosis, and before at left, and the right image 1 month after TAVI. And you can see on the left the changes in terms of myocardial deformation, with a global strain very low of 5.7, ejection fraction of 30%, and 1 month after you can see a significant improvement, with the global strain going up from 5.7 to 13.3, and ejection fraction going from 30% to 55%. Here you can see also how you can have global longitudinal strain evolving in different stages, various degrees of aortic stenosis, all of them with preserved ejection fraction. And you can see from right to left the abnormalities in terms of mild aortic valve stenosis with an area of 1.9, global strain 21.8, moderate and severe aortic stenosis. And usually it follows the abnormalities in terms of the severity of aortic stenosis. It has an impact, and we knew that that there was an impact in terms of left ventricular function. But as you can see here, in all these cases, there is preserved ejection fraction. So if we would use ejection fraction, it will look normal. But when we use global strain, you can see that there is a decrease in global strain, meaning there is already an impact in left ventricular function when we assess by this parameter. And actually, we already have data which is summarized in this slide that shows that there is an incremental prognostic value when we add global longitudinal strain to the traditional risk factors. Here for aortic stenosis, here for aortic regurgitation, and here for mitral regurgitation. And when we add global longitudinal strain, there is actually a significant incremental prognostic value of adding left ventricular strain in this assessment of patients with these different forms of valve disease. And here you can see a normogram of the estimated risk of death at 5 years when we use global longitudinal strain in valve diseases for aortic stenosis. You can see that it's about 7, it's used minus because it goes in a negative wave, minus 17 global longitudinal strain for aortic stenosis. It's about 19 for aortic regurgitation and about 21 for mitral regurgitation. The threshold that with that abnormality lower than that, it has some importance in terms of the estimation of the risk of death at 5 years for patients with these different conditions. So we already have some data that can help us to include this information to assess not only the severity of the impact of valve disease in left ventricular function, but also in terms of prognostic assessment in the individual patient. Another parameter that can be used is the use of mechanical dispersion, which basically looks at the changes that occur in the different segments of the left ventricle. So this is assessed by speckle tracking, in this case in the 4-chamber view. These are 2 patients with severe aortic stenosis and preserved ejection fraction. But this one has 43 milliseconds of myocardial dispersion and this 70. So the lower the better in terms of myocardial dispersion. So this shows that this patient has more significant impact in terms of abnormalities in left ventricular function by using this method of looking at myocardial left ventricular mechanical dispersion by using this speckle tracking. There has actually been also some integration, and I will not get into details of other imaging modalities, but by integrating all the information that can be provided by different elements, you can see, for instance, this was recently published, and it shows that the integration of multimodality left ventricular assessment, in this case in aortic stenosis, may help us to identify the better timing for intervention in these patients. And here it includes different imaging modalities or different modalities, and the use of echo, including the use of global longitudinal strain, can actually add information that help us to identify when is the best timing for intervention in the individual patients. So I would say, to summarize, that the use of strain imaging in valvular heart disease can be a useful complementary echo method that can help us to identify the patients at risk of developing symptoms or poor survival and might assist in therapeutic decision making. Although, again, the level of evidence that we currently have has not been significant enough to be already included clearly in the guidelines. It is mentioned in all the guidelines, but it's not still included as a concrete indication for management of these patients. But I strongly believe that more and more information will help us to identify the best timing for intervention in these patients. And again, the conclusion also that it's important we improve our understanding of the complex interaction between, for instance, loading conditions, which we know affect this type of parameters. They are load dependent, chamber geometry, and contractility, which is necessary for the better interpretation of myocardial deformation in order to draw appropriate conclusions in patients with valve disease. So in summary, the use of speckle imaging, the use of global longitudinal strain, so the use of myocardial deformation parameters, has improved the way we understand the abnormalities in left ventricular function in patients with valve disease, either aortic or mitral valve disease, and can help us to identify the best timing for intervention in these patients, which is the main question that from a clinical standpoint we have when we have to manage these patients. So thank you very much for your attention.